This is Dr. Larian, and I am late this morning to do a live question and answer session. We have a few questions it looks like that have come in that I'm happy to answer and go through. So let's go ahead and start. The first question comes from Jenna Mandel. Question is, surgeon was not able to find the fourth gland, so she removed 2.5 glands. 2 weeks post-op, follow-up labs yield a calcium of 9.4, which is in the middle of normal range, and PTH of 73, which is elevated. Doc says this was a curative successful surgery. A referral to genetics for MEN1 is scheduled. Age 25, lots of kidney stones, all glands hypercellular. Should the fourth gland be found, will 2.5 removed stop the kidney stones? Very good question, Jenna, and a very complex answer to that. So let me go ahead and explain. So first, about 2.5 glands being removed rather than anything else. So that has to do with the development of parathyroid tissue, right? So when parathyroids are developing, in the 6th week, when you're in your mom's belly, your head is split in 2 pieces and it's fusing together, which is why you have this line in the middle of our upper lip. That's one of the fusion points. But the 2 sides of your throats are separate and they are forming pouches. The first pouch here turns into the ear. The second pouch turns into the tonsils in your throat. Third pouch turns into the lower parathyroid and the thymus gland. And the fourth pouch turns into the upper parathyroid, right? So interesting that the third pouch, the upper pouch, migrates more and comes down. So that's why sometimes the parathyroid can be hiding inside the thymus, right? Because they migrate together and they can fuse. The thymus and the parathyroid can fuse. So the parathyroid, instead of being down here, it's actually inside the thymus. Sometimes the parathyroid overshoots and goes all the way down in your chest. Sometimes 2 parathyroids, as they're migrating, fuse, and the person has only 1, 2, 3 parathyroids. 3% of people have only 3 parathyroids, okay? And so it does happen. If your surgeon does a full comprehensive surgery and looks all around and finds 3 abnormal parathyroids, what is your surgeon to do? So, generally speaking, what I would do is check your PTH level, and let's say your PTH was 110, right? Normal range is 15 to 65, right? Your PTH is at 110, right? You find these 3 parathyroids, right? And let's just say that this parathyroid, let me draw it here. This parathyroid is the smallest of the 3. This one's big, this one's big, this one is smallest. I would take out this one, the 2 biggest ones, and then cut the smallest one in half, leaving the blood vessel that goes in and out intact at the other half, right? So, and then I would check your PTH. If the PTH comes down dramatically from 110, let's say, to 35, 30, and 28, right? It comes down on plateaus. That tells me that probably, more than likely, you only have 3 parathyroids. On the other hand, if it doesn't come down, that tells me that there's a 4th parathyroid somewhere, right? So if the number goes down from 110 to 85, let's say, and hovers around that number, then this tiny little parathyroid is not the fourth one, right? And there's another one. And I would continue the exploration, right? Now, when you're doing parathyroid surgery, you have a limit to how much you can see through an incision in the neck. You can only go to the upper chest, go a little bit behind the chest bone and collarbones, right? You can go, all, up to the upper part of the neck, like the voice box area and up there. But there isn't more that you can explore. You can look behind the carotid arteries. So let's look at the anatomy. So when you make an incision down here, right, you have access to looking from to this space. And in this space, you can look behind the arteries and in between the artery and vein. You can look behind the breathing tube here in the middle, the trachea and voice box area, right? Obviously, you can look behind the thyroid, you can look at the thymus, potentially remove a portion of the upper part of the thymus on both sides, or on the side where you found only one parathyroid, I'm sorry. So this was the smallest parathyroid, these two were the biggest, and this one was missing, right? So this one was taken out, this one was taken out, and this one was cut in half, right? And you're looking for this particular parathyroid you haven't found. So I would remove the thymus and look inside of it and check PTH again. I would look in between and deep to these artery and vein. I would look behind the throat or the breathing tube, the trachea. And potentially, if on ultrasound I had seen any nodules inside the thyroid gland, I would potentially remove that nodule, or I would remove a portion of that thyroid, and so on, and check again. That's the limit of what can be done in that space, okay? So those are the constraints, right? And that's why PTH testing is really helpful, because it allows you to see during your surgery if you need to do more, or if 2.5 glands is enough. If you're part of the group that has only 3 glands and 2.5 is the absolute right surgery. Had you taken all 3, it would have been a problem. Now, you had hyperplasia in all 3 glands, which means all of the cells in all of the glands were abnormal, right? I in particular try to have all my patients who have hyperplasia, who have primary hyperparathyroidism, primary meaning it's not secondary to kidney failure, to vitamin D deficiency, or something else. Primary hyperparathyroidism, and they have all 4 glands involved. To me, getting all the cells in all the glands abnormal has to have either a massive radiation exposure, right? You were close to Chernobyl, Hiroshima, you had radiation treatment for some sort of cancer in your neck, and 10, 15 years later, you had hyperparathyroidism. Yes, those are good. Those are reasons that are understandable, creating mutations in all of the parathyroid glands. But if you haven't had anything like that and you have all of the parathyroid glands be abnormal, there must be a genetic base to it, right? So I always send all my hyperplasia patients for genetic testing regardless of their age, right? So the fact that you're getting genetic testing for MENs is very important, or some of the knowns. There's 9 known genes that cause hyperparathyroidism. Genetic testing for that is important. My concern is that your calcium was 9.4 after surgery, 2 weeks after surgery, and your PTH was 73. Now, that can happen if you have essentially a version of hungry bone syndrome, right? So you can't trust this number. If you were my patient and you came in and 2 weeks after surgery you had an elevated PTH, I wouldn't tell you that you're cured. I would say, it's not clear to me. You may have hungry bone syndrome, and the bone is grabbing the calcium out of your bloodstream, so your remaining parathyroid is working hard against the bones, so it's producing extra PTH to try to fight it, right? Let's continue to monitor. This may take 6 months to a year. Let's continue to monitor and see what's happened. If the numbers over time the PTH number comes down, calcium stays in the normal range, then great, you're cured, right? It's just that it's too early for me to be able to say that. And do we need to find a fourth gland? It really all depends on what your PTH testing showed during surgery and what your PTH does, your calcium and PTH do over the next year. So too early to tell, possible that you've been cured. Hopefully that is the case. Hopefully you are part of the 3% that had 3 glands and you're already cured. All right, my dear? Very good question. And best of luck, really. Crystal Blackwell. Should everyone under the age 40 diagnosed with multi-gland disease be tested for MEN? Oh, well, everyone, I feel, should be tested for do genetic testing for hyperparathyroidism genes, right? If these are the MEN syndromes, but I think everybody should be tested. I mentioned that before, because they could be, they could have a known gene, right? These are some of the genes that we know are related to hyperparathyroid disease, not necessarily always hyperparathyroidism. There's 9 that we know are related to hyperparathyroidism. In any case, if you have the known genetic mutation, then you can let your family members know, your siblings, your children, to be tested so that they know, you know. And I was made aware of this by a patient I had years and years ago that came from Europe and had the hyperplasia. And lo and behold, we did testing. She was amazing and so good. And she had been told she doesn't even need surgery, right, in her country of origin. She came, she had the surgery, then she went and did genetic testing, discovered she had MEN, and then found out that her son and daughter both had it, and both had to be treated, right? And so it's important to know, right? And genetic testing is not difficult to do, fortunately. You just give a blood sample, and they do the testing and look for it and let you know. So it's well worth doing. So I recommend it for every scan. Also, should a younger person still get DEXA scan? I'm 38, diagnosed with primary hyperparathyroidism in 2020, had surgery in 2023, 2 glands removed, numbers back up. Okay, being so young, right, and if you have not had any fractures, any unexpected fracture, like you pushed hard on something and then you got a wrist fracture, that's you know, a disproportionate fracture to the force, yes, you should do the bone density study. But if you haven't had a history of fractures, right, if you're younger, less than 50, I would say, right, and you have hyperparathyroidism that's treated and your numbers normalize and you're good, you don't necessarily need to do a bone density study, because most people who have hyperparathyroidism and have a successful surgery will have improvement of their bone density. Right? This is the study that was done at Columbia University over a period of 20 plus years. And they showed every patient, so half the patient population of the 116 people, half of them had surgery, 59, right? And all of them who had surgery had improvement in bone density, and their bone density was 10% higher 15 years after surgery as compared to before surgery. So if you're young, healthy, haven't had fractures, your bone density is going to get better, right? I don't know if you need a bone density, okay? Let's see, what else are you asking? So after in 2023, two glands were removed, numbers back up, calcium 11.1, very high, PTH 113 high. Endocrinologist says he believes I have hyperplasia. I agree. So I don't, Crystal, I don't know what they did for you during your first surgery. I don't know if they removed the 2 glands and did PTH testing, and if your PTH dropped appropriately during surgery or not. You know, all of that is helpful information. But let's assume that they did. Let's assume they did PTH testing, During surgery, after finding 2 glands that were enlarged, maybe 2 glands were seen on scans, and then they came out and they were good, right? And now your numbers are up. So in the setting of doing PTH testing during a surgery where the PTH drops, right? So I have a PTH of, in this scenario, 180, and I remove this gland or this gland, right? In either one of these scenarios, scenario A or B, okay? And the PTH drops, goes into the normal range and stays low, right? And I feel like I have a successful surgery, it's over, and 6 months later, a year later, I'll look at the numbers, and the numbers are high again, 11.1 and PTH of 130. Okay, so both numbers are elevated, right? What are the reasons? The two things that I've seen in my experience when I have a failed surgery, which happens 3% of times. I failed surgery, well, I call it a failed surgery. The surgery wasn't a failure during the time of the surgery. What I call it failure should be called persistent disease. That within a year it shows that you have hyperparathyroidism again. I feel like it's called persistent, right? And in that scenario, I found either you had microscopic disease in another gland that didn't have a chance to grow yet, or you had an adenoma that grew in the background of hyperplasia. So all of these glands are hyperplastic but small, and you had a big adenoma with high calcium set point that overpowered everything else. So once this was taken out, the other ones had a chance to grow and get bigger. And in my experience, this adenoma on the background of hyperplasia is the more likely scenario than a second adenoma, right? So in your scenario, if they took 2 out and both of them were abnormal under the microscope when the pathology report came back and it was hyperplastic, and your numbers are up again, more than likely the other 2 are problematic. And if during your first surgery they took out, let's say, they took out these 2 and they saw the other 2 and put a little metal clip, titanium clip next to it, then the surgery is easy. They can go in there and immediately find those, remove the biggest of the 2 or do scans and see which one looks bigger and take that one out and check PTH again. And if the PTH goes down from 113 to 35, then you're good. If it goes from 113 to 65, right? Not a 50% drop, then you may have to go in and remove a little bit more of this one, right? Making sure the blood vessels are not being removed or cut, right? And check PTH again. That's the scenario. So Crystal, I agree with your endocrinologist. You do have hyperplasia and you should treat it, right? Especially because you're so young. In this scenario, I would do a bone density study since your numbers are up again and you have hyperplasia. Hyperplasia means more than likely you were born with this condition. It is genetic. You should do genetic testing. And all your life, your parathyroids were not functioning properly, right? And so your bones may be compromised. Now, this is something that I find really interesting is in a normal parathyroid environment, you have surges in PTH at 6 a.m., 10 a.m., and sometime in the afternoon, right? And these surges are not long-lived, right? And in the in-between times, your PTHs are normal and reacting to your calcium level, right? During these surges, the PTH goes to your bones and activates a cell called osteoclast that eats away at your bones, and the remaining time of the day, with the PTH being in the normal range, osteoblasts, a different kind of bone cell, make new bone. So you're constantly getting bone regeneration, which is why our skeleton is completely replaced every 11 years, right? And so if you have hyperplasia and your PTH is a constant high, you're not getting the bone replacement so much, and your bones will naturally be weaker, right? So that's why I would think in your scenario, a bone density study is important. Good questions. Thank you, Crystal, and good luck. Linda Williams, can having sorry, let me put my phone on silence. Okay. So Linda, can having hyperparathyroidism cause gallstones? No, it doesn't. It doesn't cause gallstones. They're not made of calcium. Um, uh, the demographic of people who get gallstones overlaps with people who get the population that gets hyperparathyroidism to a little extent. Gallstones are more common in women who are in their 40s, right? And women in their 40s and 50s who are a little overweight tend to have gallstones happen more often, right? Now, I'm not a general surgeon, so that's not my specialty, but that combination somehow affects the gallbladder to form stones, right? Now, the chance of hyperparathyroidism increases in both men and women, but especially in women starting at the age of 40 and going up. So there's a little bit of overlap in women who are in their middle to later ages getting hyperparathyroidism with getting gallstones, but there's no causality. There's a correlation, but there's no causality. One does not cause the other, okay? After the successful removal of one diseased gland in August 2024, the pain I experienced prior to my operation continued around my bra line. In March 2025, doctors suspected I had a gallstone. This was confirmed in June after an ultrasound. Now I'm awaiting removal of the gallbladder. And I'm based in the UK. Yeah, I mean, having the discomfort on the left side, on the right side, I'm sorry, next to, in the area where your bra line is, does point towards gallstones being the issue, and an independent issue, not related to hyperparathyroidism. I'm sorry you have to go through 2 surgeries, but that's the luck. That's the luck, unfortunately. I'm sorry again, Linda. Good luck with your surgery. All right, Hannah Hattinen. What do you think about the following results? 2 PET choline not showing anything. On April 9th, a 9mm adenoma was found through exploratory surgery. IOPTH was used. So the lab test shows, let's see, calcium is 1.3 millimoles, range is 1.16 to 1.3, so right at the upper end of normal. Ionized calcium was 1.31, so 1.01 unit above normal. Alkaline phosphatase is high, magnesium is normal, kidney function is normal, vitamin D is 89, so normal, and PTH is 50, normal is 15 to 65. So your calcium, so this is calcium. The calcium is, if the screen is the range of normal, your calcium is on the right at the cusp of being abnormal, and your PTH, instead of being low, which is the way calcium and PTH react, your PTH, instead of being low, is up here. So that's an abnormal relationship. Those numbers are not normal. So it looks like it looks like you had hyperparathyroidism, and it looks like you had a successful surgery and one was removed. You're not sharing your PTH, the intraoperative PTH number, so I don't know how successful the surgery was, but hopefully everything was done appropriately, and you feel better. All right, my dear. Andy Moss, I've got hyperparathyroidism, jaw tumor syndrome. I've had 3 surgeries over the years, resulting in all parathyroids being removed. Wow. So hyperparathyroidism jaw tumor syndrome is really a rare genetic disease. It's caused by mutation in CDC73 gene, I believe. Let's see. Yes, there you go. Oh, and this is an autosomal dominant disease, which means that every child that gets this gene would have this disease. That makes it difficult. So, genetically we have 2 copies of every single gene, right? And so 1 copy comes from mom, 1 copy comes from dad, right? And in an autosomal dominant, it doesn't matter what the copy from one parent is, the dominant gene controls and creates either the good things or the disease, right? And in cases of hyperparathyroidism, jaw tumor syndrome, the gene that created the disease for you, Andy, can create it for your children, right? So if it's passed on to any of your children, they would get it. There's a 50% chance, because you have 1 gene that was passed on from mom, 1 from dad. One of them had this disease and was passed on to you. If that gene gets passed on to your children, it'll get it. If the other gene gets passed on to your children, they won't have this disease, right? So please make sure you really, if you have children, you really look into it for them, and make sure your siblings look into it. This is a problematic gene because it also predisposes you to parathyroid cancer. So, and I'm sure you know all this, Andy. I'm just letting everybody else know about this disease. Anyways, so you've had 3 surgeries. I have had 0 PTH for 15 years. So they removed all your parathyroids, okay? And you must be in high doses of calcium and calcitriol, not regular vitamin D, but calcitriol, right? Because you need PTH. So you need PTH to go to your kidney, activate an enzyme called 1-alpha hydroxylase that turns inactive vitamin D3, the one that you test in your bloodstream, the one that's in the supplements, to the active form, calcitriol, which is what does all the work of vitamin D as it relates to the calcium parathyroid system. Okay, so with calcitriol, the absorption of calcium goes from 20% all the way up to 80%. So without calcitriol, you're absorbing very little calcium from your foods. Okay? Anyways, so you must be on a lot of calcium and calcitriol, right? So my kidney failed 15 years ago, right? And I was put on dialysis for 2 years, still 0 PTH. So if your PTH was 0, they either took out all of your glands, or what little residual gland they had left behind was being suppressed by the calcitriol, right? So if you had large doses of calcitriol decreases PTH production and parathyroid growth, okay? All right, let's see where we're going with this. I had a kidney transplant, congratulations, 18 months ago. After 6 months, very low PTH was recorded. My PTH has risen slowly over the past year. It is now within normal range. Oh, okay. then you must have been taking large doses of calcitriol, right? And during your surgeries, they must not have removed all of your parathyroid tissues. Even if they remove 4 parathyroids, but 10 to 20% of people have 5 or more parathyroid glands. So they must have been some small amounts of parathyroid tissue left in you that was suppressed by this calcitriol, right? The calcitriol was suppressing your gland, and once you got the kidney transplant, you didn't need to take calcitriol anymore because you had a kidney that could make calcitriol, and your numbers coming up. Wow, that's fascinating. I have not seen that, but that's amazing. Good for you. How's it possible if I have no? You must have some glands. Will it continue to rise? Well, I mean, it all depends. Generally speaking, people who have hyperparathyroidism, jaw tumor syndrome, if I remember correctly, they get parathyroid adenomas, not necessarily hyperplasia, right? And so if what they removed were glands that had adenomas on them, right, it's possible that the remaining gland does not, but you have a genetic predisposition, so you may get an adenoma in that one, so you have to continue to watch it, right? Or this could be an adenoma that's growing in the past year or so, and so just keep a watchful eye. It doesn't, based on the rise, it doesn't necessarily mean you need surgery, right? It just means you need to keep an eye on it to make sure, and you need to really, I would say, check your calcium and PTH monthly, right? And I'm not trying to scare you, but as you well know, people who have the hyperparathyroidism jaw tumor syndrome have a propensity for developing parathyroid cancer. And if these numbers are rising up quickly, it raises the concern for a cancer. So if your numbers are going up, and if I would check it monthly, if they're going up quickly, you really need to have your surgeons get on it and find the parathyroid on scans and get it out as quickly as possible, right? But if those monthly checks show that in the next 6 months your numbers have plateaued and are staying in the normal range, then you have a healthy normal parathyroid. You don't need to worry about it. You can decrease the frequency of testing at that point. Good luck. Thank you for sharing, Andy. Azadeh. Before my parathyroid surgery, I had long-term pain in my pelvic area. The pain in my muscles and bones became very severe for 2 months leading up to the surgery. After surgery, and especially after starting calcium supplements, the pain improved and my muscles, which had become stiff, got a little better. However, I still have pain and cramping in my thighs and buttock area, and I sometimes experience tingling in the soles of my feet. It's interesting. I have had a handful of patients who experienced neuropathy in their feet, which was, they had a little bit of it before surgery, but it became more obvious after surgery. I have more who had tingling and things that went away and faded, but I have a few that it got worse. It sounds like that's the case for you as well. It has been 4 months since my surgery. My most recent parathyroid hormone level is 17.9, great, normal. Calcium is 9.7. In addition, I'm taking 3 tablets daily of a 1,000 milligram calcium citrate, which contains magnesium, vitamin D, and vitamin K. Great. Okay, so you're not really asking a question, but I'm assuming your concern is about the pain that you're having and cramping in the. It's early on. You're going through calcium rebalancing. You may want to check your magnesium also to make sure you don't have low magnesium levels, and potassium, and continue to monitor. These improvements continue to occur up to. I've even seen improvements up to 4 years when I do my surveys and I check my patients 4 years later. Their surveys come back as even better numbers as compared to 2 years and 1 year and 6 months. So there may be improvements. I would suggest that you check magnesium and potassium levels, and supplement if you need to. Otherwise, continue to be active and exercise to force your muscles to rebalance faster. All right. Good luck, Azadeh. Yolanda Mead. Hello, Dr. Larian. I'm hoping that you are able to give me some advice on a referral to an endocrinologist. I'm authorized to see endocrinologist before I can see surgeon at UCLA. Oh. Unfortunately, I don't know the endocrinologists at UCLA. And the reason for that is that the endocrinologists at UCLA only refer to the surgeons at UCLA. So we rarely cross paths. For me to get experience as to how brilliant and how interested they are in parathyroid disease. You know, the problem with parathyroid disease is that endocrinologists most of the time don't treat it, right? So they don't have a good feel for this disease. And so as compared to diabetes and parathyroid tumors and cancers and thyroid cancers and so on, which are more commonly seen and more interesting to them because they tend to follow those patients for a lifetime. They don't really treat hyperparathyroidism, and they don't get to see these patients in the long term. So not a lot of them have a lot of interest, and I really don't know. I have worked with some of them on one-off basis when some patients didn't want to see the UCLA surgeons and came to see me, but those are less common cases. So I can't tell you that there's any one of them, unfortunately, Yolanda, that I know to be have more expertise or more interest in hyperparathyroidism. All right, I'm happy if you'd like to send me. Oh, you have your numbers, okay? Your ionized calcium is 1.27. Upper limit of normal is 1.29. Regular calcium 9.8. Upper limit of normal 10.4. Vitamin D is 58 normal. Bone density studies show osteopenia. PTH is 57. Your range being 11 to 51. So calcium is on the upper side of normal. PTH is slightly elevated. All right. So and you have lots and lots of symptoms. Okay. Okay, Yolanda. You're going to have a little bit of a problem at UCLA. It looks to me that you have what we call normal calcemic hyperparathyroidism. The surgeons at UCLA don't like treating normal calcemic hyperparathyroidism, and I don't fault them. The data out there, even though when I read the data, I still think there is a population that need help, especially symptomatic populations, right? But they generally speaking don't like treating normal calcemic patients. Let me see if you mentioned anything about bone density. Yeah, your bone density shows osteopenia, right? And you're 57 years old. You're gonna have to see if the endocrinologist will listen to you. This is what I would do, Yolanda. I would go in there, right? I would make a table. I would make a table of your numbers. Let me show you what I mean. I would make a table that something like this, that has your calcium, PTH, vitamin D, dates, separate dates, what the numbers are. Show them that you don't have an inverse relationship. Talk to them, say, hey, if the range of PTH is wide, and during the course of the day it responds very aggressively to minor changes in calcium, why is it that my PTH is always in the 50s going across, right? And my calcium numbers are on the upper side of normal. So if I have a normal parathyroid function, isn't it that when my calcium is all the way up here, my PTS should be lower? And why is mine not suppressed, right? Ask questions. Don't, this is frustrating and I'm sorry I have to say this, but it is very easy to dismiss women in the Middle Ages and tell them they have other hormonal issues, right? So you have to make a convincing argument, right? And you have to, hyperparathyroidism makes you forgetful and makes you be irritated and less patient, right? Which may seem erratic to a person who doesn't know you, specifically this doctor. You are using the endocrinologist to get you to be treated appropriately, right? So you have to go in there, despite the illness making you feel not yourself, you may have to go in there and seem very rational and in control of the situation, of your conversation, right? And this is advice. I'm not labeling you. I'm just giving you advice. You go in there prepared with a table that has all the numbers in, with a list of symptoms, and I would go to my webpage. This web on the parathyroid.net. You'll find this handout, right? And you can take this in and show it to them. It has the table. You can put your numbers in, right? And mark off whatever symptoms you have on here. Show them that it looks like you have normal calcemic hyperparathyroidism, right? And then the second page of this is what needs to be done. You've had the bone density study. Let them know you need abdominal CT scan to make sure there's no kidney stones, right? The latest guidelines recommend that a bone density is not good for the spine, that you may need, let me show you. So download this, but also show them this. Let me find. The latest guidelines for hyperparathyroidism. Show that you need to check for vertebrae by doing an X-ray or CT or MRI or a VFA bone density study for the vertebrae, because the DEXA scan is not good at showing it, right? And sorry, I'm just trying to, yeah, so do these things, make sure they do, the full testing is done for you, right? And these are what's recommended by the International Consensus Group, okay? To all this testing is done for you, right? And know that they may throw resistance and say, I understand what you're saying, but I feel horrible, I'm only 57 and I feel like I'm 90, right? I'm willing to undergo a full workup. I'm sure you've already done that, right, with the endocrinologist, but let them go through their process so they make sure they rule out all other things that could give you all this, right? And when they say no to you, which they will, right, say, I understand what you're saying, but please explain to me, why is my calcium and PTH not following an inverse relationship, right? There is a reason for it, right? Please look at everything for me. Let's look in detail. Let's make sure one way or the other. And then once they see that that you're just building something with them, that you're in partnership with them as opposed to confrontational with them because they don't know what they're talking about, then they're more likely to help you, right? So you're essentially using them to help you get things done. That's what I tell my kids. You're going to school to use the school to get the muscles in your brain to exercise so they can do more things for you later in life. You're not there to just do homework. You're using them. So in your case, you're using your doctor. You gotta finagle it. I'm sorry. I'm sorry this is the way it is, right? But this is the way it is. Okay? Best of luck, my dear. But if you want to send stuff to me, for me to look at it for you, I'm happy to do it. Right? You can contact my office and do that. Emmy Bob, do you offer second opinions on thyroid ultrasounds? Sure. I can look at your thyroid ultrasound, look both at the thyroid and parathyroid. Let's look, see if I can find anything. Okay, those are the questions that were here before. Let me look at the questions that have come in while we were speaking. Okay. Ludmila Tuevska. Hello, Ludmila. I'm 64-year-old, kidney stone since 24 years old. 40 years of it, I'm sorry. Now I have osteoporosis, kidney stones, PTH is 40, calcium is 9.9. I found old labs from my country, Europe, and I was 27-year-old, calcium 10. Then 34, old calcium 25.1, 2.51, sorry. Always was considered when younger I have hyperthyroidism. Now my endo thinks I have hyperparathyroidism. I agree. I think you have it too. Your calcium is on the upper side of normal, your PTH is not suppressed. Okay? Now my endo thinking I have hyperparathyroidism. Maybe due to renal calcium leak, suggesting a 3.5 grand removed. Well, hold on. You need to do a full workup, right? And a full workup for this is going to include looking at all the other causes of calcium elevation, right? And these are them, right? Vitamin D deficiency can cause it, right? And so you have to look at your vitamin D if it's a low supplement. Low calcium intake, so you have to check your 24-hour urine calcium. 24-hour urine calcium will tell you if your calcium intake is poor or if you have renal calcium leak. So people who have renal calcium leak means that their kidney leaks out calcium in the urine, right? So you have high calcium in the urine, normal calcium, and long history of kidney stones. That's possible. A 24-hour urine calcium will tell you that. And if that's the case, once you take this diuretic medicine called hydrochlorothiazide, right? That's all you need. That corrects the problem. Your PTH comes down. Your bones have a chance to improve their density. And you will feel better, and you don't need surgery for that. Okay. A kidney function, you have to look at your kidney function, right? Malabsorption can do it. Malabsorption would look similar to low calcium intake in that your 24-hour urine calcium would be low. These medications can cause it. This is for breast cancer. These two are for osteoporosis. This is the diuretic that I was talking about here. If you take that, that may falsely elevate your PTH or falsely elevate your affect the calcium PTH system, right? But if you have this condition, if you have renal calcium leak, it'll correct it, okay? Or lithium for bipolar, if that's mistaken. So if you don't have any of those. Now, rarely people have activated vitamin D issues. By that I mean the activated vitamin D that goes to the intestines and increases the absorption of calcium from 20% to 80%. As we age, we become less sensitive to that vitamin D, and we may need higher concentrations of it to get the same absorption, right? So some patients just need activated vitamin D supplementation, not the regular over-the-counter vitamin D, right? And that may be it. Okay, Ludmila says, took thiazide and calcium was 10 still, PTH lower at 32. Is it possible I've had hyperparathyroidism? It's possible, right? If you took the thiazide diuretic, the thiazide is hydrochlorothiazide. HCTZ, the other name for it is the thiazide diuretic, and it looks like you took the thiazide diuretic and your calcium didn't go down, right? You know, Usually when people have renal calcium leak, their calciums are normal or a little bit on the low side, right? Your calcium is on the upper side of normal. You took thiazide, it didn't go higher, stayed the same number, but your PTH came down. It's possible. But you know what I would do in your scenario, Ludmila, is I would look at your calcium, PTH, vitamin D, activated vitamin D, magnesium, 24-hour urine calcium, a few months after you start the thiazide, right? Like 3 months, right? Look at all these numbers, see how they've changed, right? If your 24-hour urine calcium was really high and came into the normal range with the thiazide, your calcium is still 10, it hasn't gone up, right? Or hasn't changed. And your PTH numbers are, instead of going to low, they're ranging from 30 to 60, right? And staying on the upper side of normal, then more than likely you have probably hyperparathyroidism also, right? You may have renal calcium leak, but you may also have hyperparathyroidism, right, in the background. And it is also possible that if you have renal calcium leak for an extended period of time, your parathyroid glands become secondarily hyperparathyroid, all 4 of your glands, and then if it stays in that state for too long, they may become tertiary hyperparathyroid, which means they no longer look at the level of calcium, they're just producing extra PTH. That's a possibility as well. Very good question. You need to do a little bit more work to clarify, but it's possible that your doctor is right and you're going to need surgery to treat hyperplasia. Kelly Torres, is this just for a parathyroid? I have a mass in my Yes, Kelly, this is for hyperparathyroidism. Parathyroid glands are behind the thyroid, parathyroid next to thyroid. Parotid is the gland up here, the saliva gland. So not on this one. All right, Rachel Kitty, is there a correlation with low alkaline phosphatase and hyperparathyroidism? I have chronically low alkaline phosphatase. No, there isn't. Not low. Hyperparathyroidism can cause elevated alkaline phosphatase because alkaline phosphatase is both in the kidney and the bones. And when you have bone loss, your alkaline phosphatase can go up. Ben Carlson. Hi, Dr. Larian. A third operation in Sweden is quite unlikely. I know, Ben. We have spoken many times. It was discovered, okay. So you still have high calcium and high PTH. Vitamin D is normal. Osteopenia only at the hip, neck, stomach issues, but not actual pathologies. Arthrosis here and there, but I can move around without help. How many years of life can persistent hyper cost me without reoperation? And Sensibar just makes me. Okay, I can't give you exact numbers, Ben. There is research that shows that it reduces a few years of life, anywhere between 2 to 7 years, right? How reliable those numbers are, I'm not very sure on because it's a hard research to do. But imagine if you're driving a car, right, and the motor oil you put into it is not the motor oil that it needs. It's a different kind. So your engine runs inefficiently. That's hyperparathyroidism is. Your body running inefficiently, it's going to wear and tear faster, right? So it will break down faster. And more important, with the number of years you live, is the quality of your existence. I know it's hard for you to arrange for a third surgery in Sweden, right? But you do need the surgery. You know where this parathyroid is. You've shown me the picture. It's right behind your chest bone. And I know your surgeons in Sweden say it's impossible to do, but based on what I saw, it's not impossible to do. So I would suggest that you seek someone maybe in another European country if coming to the US is too difficult for you. Tobin Member, August 26th, the ENT went to schedule surgery based on written PET scan report without seeing the disc. I decided to go for a needle biopsy, which came back Warthin's. Oh, so another parotid question. So I'm not going to go ahead with surgery. Tumor is not painful or bothersome. isn't noticeable. Now it's a little swollen. I'm taking am I making, well, if it's a Warthin's tumor, which is a benign tumor that doesn't really turn into a cancer, um, and if it's not big enough to bother you, then I think you are making the right decision. I would have to see the biopsy report myself to tell you how certain the pathologist sounds and if they saw enough of the components to be certain, right? But if they are, then you have the choice of not doing surgery, right? If it's not getting bigger, if it's not giving you pain, if it's not affecting your facial nerves, then you're good. All right, Rachel Kinney. What about having high urine calcium before and after successful surgery? Mine recently was 227. What is the cause? What can be done when you can't take thiazide diuretics? My intake of calcium in my diet and calcium is over 1,800 to 2,000 milligrams a day, spread out throughout the day and night. No known absorption issues. I'm taking 4,000 units of vitamin D and K2 daily, high magnesium foods daily. My blood calcium is 8.8 to 9.7 post-op. Vitamin D is at 30-33, PTH 43-56. I'm coming up on 6 months post-op. I don't routinely check 24-hour urine calciums after surgery. That's not the measure. For me, it's the calcium in your bloodstream and your symptoms. If you're not having numbness and tingling, that means your calcium is not low, right? And if your calcium is on the laboratory test looking like a lower number, 8.8 and 8.9, which is still in the normal range, right? And you're not having numbness and tingling, then your body is okay with those numbers, right? You shouldn't be just chasing a test. You should be chasing how you feel. So that's what I would suggest. Anna Magnuson. I was operated November 7th last year and I'm thinking of trying to fast. You once talked about fasting. What was the best way to do it? My life is totally changed. I feel great and I have a lot of energy now. The fasting that helps your stem cells get going is 5-day water fast. Not for the faint at heart, but very doable. You have to build up to it. I don't think you can just jump in and do a 5-day water fast. You may want to do 2 days. The first 2 days are probably the hardest. The third day is the hardest. But you may want to easily go into it, and then once you got it going, twice a year. 5-day water fast twice a year so you can get your stem cells stimulated. Hannah goes on to say, I had primary hyperparathyroidism for 17 years, operated in November last year. My life has changed. I feel good and have a lot of energy now. Great. I'm so happy to hear it, and I'm so happy you're sharing, Anna. Thank you. Emily Hasley. I had successful parathyroid surgery May 25th, but recently diagnosed with hypothyroidism, high TSH levels and other readings. Is this common after surgery? It's not common. It can happen if someone has Hashimoto's thyroiditis, meaning that they have the immune system by mistake attacked the thyroid, and so every time with each attack, there's more scarring in the gland, and it works less and less. And so, if you were borderline on your thyroid, and you have a surgery that affects the blood vessels around the thyroid and gives it a little bit less, it just pushes you over the ledge. It probably means that even if you hadn't done surgery at some point in the near future, it would have happened. But maybe the surgery was the feather that broke the camel's back of sorts. But it isn't common at all. Even in patients who have Hashimoto's, it's not common. Rachel Kinney says, I don't feel well yet. I have some symptoms improved, but still have constant fatigue, muscle weakness, muscle twitching, and malaise. Right there. But if you're not having numbness and tingling, that means your calcium is not too low. It's the numbness and tingling that tells you if that calcium number is too low. And listen, the only thing that improves immediately is bone pain. Everything else is unpredictable. It can improve day one. I have patients who wake up and they say, I feel like $1,000,000 and my brain is clear. And I have patients that takes them 2 years to feel better with the fatigue and the muscle weakness and everything. So a lot. And Maya Asley says, I still experience excessive thirst after surgery, although my doctor is unsure of of the causes I've had calcium, PTH, salt, PTH, salts, and sugar all checked at normal. You could be, let me see, Emma, if you told us you had it you had it in May. It just may be early on, dear. You may still be going through calcium rebalancing. And give it more time, okay? Anyways, that is the end of our questions. Thank you kindly for your questions and for your attention. I hope this is helpful, and I look forward to our next meeting. Be well.